This video provides a 2025 update on the diagnosis and management of gestational trophoblastic disease, or GTD, prepared by Dr. Sanjaya Nagasinghe from Base Hospital Mawanella. According to the 2025 FIGO update, GTD comprises a spectrum of disorders, ranging from premalignant to malignant, all arising from an abnormal placenta. GTD involves abnormal placental growth, characterized by trophoblastic cellular proliferation. Human chorionic gonadotropin, or HCG, is the essential biomarker used to identify this disease spectrum, which includes both premalignant and malignant conditions. The spectrum of GTD includes premalignant conditions, like complete and partial hydatidiform moles, malignant gestational trophoblastic neoplasia, and precursor lesions, such as the atypical placental site nodule. Next, we will examine the epidemiology of GTD, focusing on global incidence rates and associated risk factors. There are significant variations in the global incidence of hydatidiform moles. Prevalence is markedly higher in parts of Asia, Africa, and Central America compared to the USA, Europe, and Australia. Regarding choriocarcinoma, there are stark regional disparities. Incidence in Southeast Asia is nearly 8-fold higher than that reported in Western nations. Reproductive age is a critical risk factor. Women over the age of 40 face a 5 to 7 times higher risk of developing a sporadic mole compared to those in the 20 to 35-year age group. The recurrence risk after a complete mole is about 1%, which is not typically observed with partial moles. Recurrent molar pregnancies are often linked to genetic mutations in the NLRP7 and KHD3CL genes. We will now discuss the genetics and pathology involved in classifying molar pregnancies. Pathological classification distinguishes between complete moles, partial moles, and various non-molar lesions, each with different clinical presentations and risks. Complete hydatidiform moles consist of hydropic villi forming vesicles, absent of normal fetal tissue. In early stages, these may be minimal, requiring careful histological examination. Differential diagnoses for complete moles include partial hydatidiform moles, which are triploid, and non-molar gestations, which can mimic complete mole morphology. The WHO 5th edition introduces a new category for non-molar villus lesions. This helps distinguish them from molar pregnancies, preventing unnecessary aggressive treatment for cases with low risk of progression. Finally, P57 immunohistochemistry helps differentiate complete moles, which stain negative, from partial moles and other abnormal gestations, which show strong nuclear staining. This table summarizes cytogenetic profiles for different gestation types, including the genetic makeup and typical P57 staining results. Short tandem repeat genotyping provides high precision for molecular diagnosis, identifying paternal genotypes and confirming maternal contribution, which is crucial for determining the index pregnancy. We now transition to the malignant forms of GTD, categorized as gestational trophoblastic neoplasia, or GTN. Choriocarcinoma is characterized by bulky, hemorrhagic, and necrotic masses. Histologically, it lacks chorionic villi and shows malignant proliferation of various trophoblastic cells. A placental site nodule is a benign lesion, often found incidentally. However, an atypical version is a precursor to epithelioid trophoblastic tumors and requires attention. Placental site trophoblastic tumors and epithelioid trophoblastic tumors are distinct malignancies originating from different types of intermediate trophoblasts. The Ki-67 proliferation index is a key diagnostic tool. Values above 10% help differentiate malignant potential in ETT and PSTT from benign reactions. Next, we will review the clinical presentation and diagnostic strategies for these conditions. Routine first trimester ultrasound has changed diagnosis, making early detection more common and reducing the prevalence of classic severe complications. Ultrasound findings vary between complete and partial moles. However, histology remains the gold standard for definitive diagnosis following uterine evacuation. FIGO criteria for GTN diagnosis include specific patterns of HCG plateauing or rising, as well as a histological diagnosis of choriocarcinoma. Ongoing HCG surveillance is the cornerstone of managing postmolar GTN. It is essential to use sensitive assays that detect all forms of HCG. While most GTN cases follow a molar pregnancy, they can also arise from other gestations. Clinicians should be alert to symptoms extending beyond simple vaginal bleeding. Finally, we will examine the imaging investigations used for staging and risk assessment. Baseline imaging includes ultrasound and chest radiography. For suspected metastatic disease, advanced imaging like contrast-enhanced MRI and CT scans is essential for comprehensive mapping. For lung CT evaluations, only metastases measuring at least 1 centimeter are counted for the clinical risk score. Larger lung metastases trigger a full whole-body imaging investigation, with brain MRI preferred over CT due to higher sensitivity for micrometastases. Moving on to the treatment of molar pregnancy, we will discuss standard evacuation protocols and subsequent follow-up requirements. Surgical evacuation via suction is the gold standard, ideally performed under ultrasound guidance. Intravenous oxytocin is used to improve uterine contractility and reduce blood loss. While curettage is standard, hysterectomy remains an option for those who have completed childbearing. Post-molar monitoring is critical. For partial moles, a single HCG test at 1 month after normalization is recommended, whereas complete moles require monthly monitoring for 6 months. Hormonal contraception is both safe and recommended during this time. In rare instances, prophylactic chemotherapy may be used if follow-up is impossible or the risk of GTN is extremely high. Additionally, while rare, a coexisting normal pregnancy with a molar pregnancy may proceed safely if there are no complications. We will now outline the current approaches to treating low-risk gestational trophoblastic neoplasia. Staging for GTN follows the FIGO anatomical staging system, which is crucial for determining the appropriate intensity of treatment. This is the WHO scoring system, which complements FIGO staging by assigning scores to prognostic factors to guide therapeutic decision-making. Low-risk GTN is treated with single-agent chemotherapy, typically using either methotrexate or actinomycin D. Actinomycin D generally shows higher remission rates. Once HCG levels normalize, additional consolidation cycles are administered to ensure full recovery. If primary resistance occurs, characterized by a plateau or rise in HCG during the first 2 cycles, a switch to an alternative single agent is required. Despite resistance, cure rates for low-risk GTN remain near 100%. We will now discuss the treatment strategies for high-risk gestational trophoblastic neoplasia. High-risk GTN, defined by a FIGO score of 7 or higher, requires multi-agent chemotherapy, with EMA-CO being the most common first-line regimen. For ultra-high-risk patients, a modified induction is necessary to prevent complications from rapid tumor breakdown. Salvage therapy is reserved for patients who fail first-line multi-agent regimens. Emerging options like immunotherapy, specifically pembrolizumab, are showing great promise and are increasingly recommended before turning to more toxic, high-dose chemotherapy pathways. Optimal outcomes for these complex cases are best achieved in specialized, multidisciplinary centers where oncology, radiology, and pathology experts collaborate on patient care. Thank you for watching this update on the diagnosis and management of GTD. For further information or to review these guidelines, please contact us at the provided email address.